So what is the expected respiratory rate of a 2-year-old? Daniel. Daniel, what's the expected RR of a 2-year-old? If Daniel is not able to respond, Ruth, what is the expected RR of a 2-year-old?
22, around 22 to 35 breaths per minute.
Where did you get that from?
Well, I'm trying to recall from the document that was sent in the group.
Yes. The
Yes, it
reference
had.
card.
Sorry?
The reference card. It's the reference card, the Pulse reference card.
Yes.
So you can open it. You can open it. So therein you'll find the normal respiratory rates. So if we are talking about a purely pediatric unit, then these reference ranges should be printed and pinned there. I mean, there's no harm. Just print and pin there so that people, when they are doing their vitals, they immediately are able to catch on what is abnormal and what is normal. So we check the respiratory rate of the child. We check the rhythm that they are breathing with. Is it regular or irregular? An irregular breathing pattern would suggest a central nervous system issue. We assess the quality of the breathing in terms of are there added sounds, presence of added sounds, whether audible or you hear them on auscultation. So that is quality. Assess the depth of chest rise. Is it equal bilaterally? And is it adequate? Or is it too shallow? Assess the effort. Assess the effort. Sec. Or the recording has been re-established, yeah? I believe it has. Yes, it's ongoing. So we want to assess the effort, use of accessory muscles, which could help you gauge the extent of respiratory distress. All right, we want to assess the SpO2, the patient. Of course, earlier we observed the positioning of the patient in order to check whether we are dealing with a respiratory issue. At C, C is for circulation. So we have said in the Pulse reference cards, you are able to identify tachypnea using those reference cards and bradypnea. Okay, so for the infant, it is 30 to 53, the expected RR. For the toddler, it is 22 to 37. For the preschooler, it is 20 to 28, if I recall. And then beyond there, now we are getting to normal adult rates. So school age child is 18 to 25, and then 12 to 20 for the adolescent. All right. At circulation, we also want to check the pulse rate. Okay, so once again, it's important to know the expected pulse rates as per age. So if we go by what we have in the reference card, the normal rate for the normal awake rate for a neonate, upper limit is 205, lower limit is 100. Okay, so greater than 205 is a Turkey, less than 100 would be a Brady. Infant, 100 to 180. Toddler, 98 to 140. Preschooler, 80 to 120. School age child, 75 to 118. And then adolescent gets to the adult rates. So if you deal with pediatrics, then these are ranges that you need to have possibly at the back of your mind. Now, additionally, we check for signs of shock. Now, in pediatrics or even adults, when we are assessing, start at the fingertips. So at the fingertips first, observe the color. Is there pallor, cyanosis? There isn't any. How is our capillary refill? Is it less than 2 seconds? Or is it delayed, which would suggest hemodynamic compromise? Is there a temperature gradient that we can appreciate? How is the skin condition? Is it warm and dry? So you start at the fingertips as you head towards the upper arm. Assess the peripheral pulses simultaneously as you assess the central pulses. Compare the two. Okay? When you get to the upper arm, do a blood pressure, do a BP. Now, there's a formula for calculating BP or estimating BP, normal BP for someone aged 1 to 10 years. Did you come across it, Ruth? Okay. So we are saying normal is about 90 plus 2 times the age. So normal systolic should be in the range of 92 for a 1-year-old. For a 2-year-old, around 94. But we are not really worried about the normal systolic. We are worried about the cutoff for hypotension. So the cutoff for hypotension, we say, for those aged 1 to 10 years, greater than 10 is greater than 90. But for 1 to 10 years, it is a systolic, so systolic blood pressure of 70 plus 2 times the age. That is the bare minimum. For anyone less than 1 year, the bare minimum is 70. And for those less than 28 days, the neonate, 28 days. For the neonate, we are saying less than 60. So 60 is our cutoff. So let me rephrase this. It should be greater than or equal to 60, greater than or equal to 70, greater than or equal to 70 plus 2 times the age. That is for blood pressure. Okay. You then want to assess the ECG of the patient. So connect this patient to a cardiac monitor and assess the rhythm on the monitor. Obtain IV or IO access, plus collect samples. So IV or IO access plus samples. D is for disability. Here, we want to identify the GCS of the patient or the AVPU. And we are saying the GCS is usually modified. The GCS is usually slightly modified in the pediatric patient, particularly for the infant. Okay? So for the infant, what is the modification? Is the modification under eye opening? Dan? Daniel, are you there?
Yes, I am.
Yes. Does the modification affect eye opening?
Yes, it does. Essentially, it's just a summary of the BCS.
For the adult. So no, I'm asking, how different is the pediatric GCS from the adult one? Is eye opening any different? Or do we still score a 4 for spontaneous, a 3 for verbal, a 2 for pain, and then a 1 for no eye opening? See, it's the same.
Yeah.
What about verbal response? Is it the same? Do you expect a child to have oriented speech? An infant, sorry.
Not really. It's not the same.
So how is it going to be different? What should an infant be doing?
Okay. Okay, an infant basically is just crying.
When they're happy, how will they behave?
And they're happy, they maybe giggle or a
They
smile.
may babble,
Yeah,
cooing,
bubble.
babbling, yeah? That is what is expected for a score of 5. For a score of 4, they are irritable but consolable. So they are crying, but they can be consoled. A score of 3, they are crying inconsolably. A score of 2, they are usually making incomprehensible sounds. So they could be grunting and such. A score of 1, there's no verbal response. When it comes to motor, a score of 6 is given to spontaneous limb movement. A score of 5 is given to withdrawal to touch. A score of 4, I believe, yes. A score of 4, yeah, a score of 4 is given to withdrawal to touch. I've shared the iteration in the WhatsApp group, so you can just have a look with me. So flexion appropriate withdrawal is a score of 4. So you inflict pain and they flex appropriately. That is a score of 4. Now, abnormal flexion, meaning the corticate posturing, would be scored at a 3. And then decerebrate posturing is scored at 2. Abnormal extension. And then a 1, there's no motor response. So the pediatric GCS is slightly tweaked because of the obvious differences in what you can assess. Now, you can also use AVPU, but you need to know that A corresponds to a GCS score of 15, V corresponds to a GCS score of 13, P corresponds to a GCS score of 8, and U corresponds to a GCS score of 6. Check the RBS of your patient. What's our expected RBS in a neonate, Ruth?
45
40 to
milligrams.
45 milligrams per deciliter. In millimoles, that comes to?
I need to convert.
2.5.
2.5.
Yeah.
2.2 or 2.5. 45 is 2.5. So 40 is, I think, 2.2. Divide by 18, yeah? Divide by 18, yes. 40 is 2.2. So for the neonate is 2 to 2.5. For the child or older infant, how many milligrams?
50 to 65.
60. 60.
60, okay.
60 as a cutoff. So 60 comes to 3.3 or thereabouts. Yeah, 3.3 millimoles. Check the pupillary response. Are the pupils equal, round, and reacting to light? And then expose and do a head to toe exam. This also marks the shift towards the secondary assessment. So ABCDE is our primary assessment. Secondary, I don't think I need to recap. It was basically a sample. So secondary, we are talking about, so secondary assessment was the physical exam that came from our E. So physical exam, obtain vitals, if there's any that you haven't obtained during your primary assessment, and do sample history. Do a sample history. Do a sample history. of your patient. Okay, that is that. Any question on the primary or secondary assessment? So let us take a 27-minute break for tea, and then we resume as from 11. So we will start by looking at a few case studies for the primary assessment. Yes, that is right. It's not 90/70. It's if you're looking at the normal BP, it is 90 plus, 2 times the age. If you're looking at the lower cutoff for systolic, it is 70 plus, 2 times the age. This only applies for 1 to 10, ages 1 to 10. Beyond 10 and above, it is 90. Less than 1, it is 70, less than 70. See you guys at 11. Thank you. All right. Welcome back. Benson, good morning. Daniel, good morning. You're back?
Morning, yes, I'm back.
All right. Ruth, you're also back?
I am.
All right. So as I had indicated, I want us to have a look at a few case studies. So remember, you start with an initial assessment, and then you move to the primary assessment, and you identify. So we'll start with Daniel. Guy is a patient. Do an initial assessment. What are your findings? Initial. Daniel, are you there?
Yes, I'm there.
Yeah.
So for an initial assessment, first of all, I can see approximately a 4-year-old boy. Currently in
We are
the
not going into those details. What do we do in initial? Initial. PAT, pediatric assessment triangle.
Okay, so for the initial assessment for the pediatric assessment triangle, we look at the appearance, the breathing, and then the circulation.
Yes. So what about the appearance?
So in terms of the appearance, in
Yeah.
terms of the tone appears to be abnormal because the child is let me say just lying there.
Okay. So reduced tone.
Then for so there's reduced tone, and then there is
Are they interactive?
they're not interactive. And then in terms of the consolability, I can't assess the consolability, but they are not crying.
Look or gaze.
Look or gaze is abnormal. Speech is absent.
Okay.
Yeah.
So if we had not yet activated, then we want to activate the emergency response team, right?
Yes, the EMT.
Okay. Move to work of breathing.
So the work of breathing is increased. The child is in visible respiratory distress. Couldn't count the respiratory rate, but he appears to be tachypnic. Yes.
And you also see
there is a supracostal retraction and use of accessory muscles.
Supraclavicular.
Yes, clavicular retraction and use of accessory muscles of breathing.
Okay. So there's increased work of breathing.
Yes.
So what do you want to start them on if they are not already on it?
Oxygen. Yeah.
Color, possibly not possible to assess. So help is coming. The next thing you do is you move to your move
to the primary assessment.
Primary assessment. So let's see the primary assessment, starting with airway. How is the airway?
So the airway, with the fact that he's breathing, I can't really assess the airway because I think it would need an
maneuver.
An on-site maneuver, yeah.
So when you auscultate, you hear lung sounds, you hear wheezes.
Yes.
So diminished lung sounds and wheezes.
Yes.
So is there a threat to the airway?
For sure, there's a threat to the airway.
Which location of the airway? Upper, lower?
The lower airway.
The lower airway. Okay. So to protect the lower airway or to open it up, if there's lower airway obstruction with wheezing, you need to do what?
Differential diagnosis of asthma. So immediately start on bronchodilator.
A bronchodilator. So bronchodilator is commenced. You move to breathing, right?
Yes.
You want to know the rate, and the rate is displayed as 68 breaths per minute. Is that adequate?
68 is actually tachypnic.
Tachypnea.
Yeah.
Uh-huh.
So
What's your
68 is
expected range for this child? This is a toddler, or at max 3 years old, maybe. So what's your expected rate for a toddler or a preschooler?
Around 20 to 28.
20 to 28. Thank you, Benson. So that is tachypnea. Okay. Dan, are you still there?
Yes, I'm here.
All right. So breathing is tachypnic. What else do we assess at breathing?
We have to do like just a full respiratory exam together with the SpO2s.
So we check rate, rhythm is regular, quality there's wheezing, depth is shallow because of the rate, and then effort, there's increased effort. Saturations are at 91%. And this is assuming this child is being nebulized with oxygen. So is that adequate?
As we said previously, we aim for hyperoxia rather than staying on the borderline. So I'd prefer them to be above 94%.
So you'd want to increase the flow rate of your oxygen. Move to circulation. At circulation, what are we checking for?
So circulation, you start with the peripheries. Look at whether there is
that
a
is after we've
here.
Confirmed they have a pulse.
Yeah, after confirming there is a pulse.
Pulse is present at a rate of 167. Is that normal for a preschooler?
That is
Dan, we've lost you.
I'm saying that is tachycardia.
What kind of tachycardia are we dealing with when you look at this ECG?
It's a sinus tachycardia.
Sinus tachy.
Yeah.
Okay. You check for signs of shock.
Yes.
So you don't see any. The peripheries are pink and warm. Skin is warm and dry. Peripheral pulses are similar to the central pulses.
Yeah.
That is their blood pressure. Are you satisfied with this blood pressure? So we've said about a 3-year-old. What's your minimum systolic?
Minimum systolic should be 70 plus 2A. Yeah, exactly, 70 plus 2A. So we are good in terms of the BPs.
So 70 plus 2a here would be
76.
76. 76. So now the other things possibly assessing is not possible. Identify, what are you dealing with? Respiratory, circulatory, or an arrhythmia?
Respiratory compromise.
Respiratory. So is it distress or failure?
It's respiratory distress.
Okay. Why do you say distress?
Because there is first of all, there is tachypnea, increased work of breathing using accessory muscles, and also identified pathology, which is diminished lung sounds with wheezes. If it would have been the other types of respiratory failure, we would have required more parameters to see.
Okay, let's leave it at that for now. We will discuss differences between distress and failure later on. Ruth, this next patient is yours. Ruth, are you there?
Yes, I am.
Okay. So there is the child or infant, I'm not sure. What is your finding at appearance?
At appearance, baby is having okay, on the tone, baby has decreased tone, it's not normal tone.
Decreased tone, interactiveness.
Can't really gauge whether baby is actually interactive, so I'd put it at no interactiveness per se. Consolability, we can't objectively tell, but baby is not overtly irritable. Look or gaze, baby just seems to be gazing. Speech or cry, baby is doing neither. So I'd say that in the appearance, I'm worried about the tone and the interactiveness is diminished. In the work of breathing, I could say baby is actually having difficulty in breathing. We can see there's lower chest wall in drawing, there's use of the abdominal muscle as an accessory muscle. There's a point in time, I can't say baby has pursed lips, but baby opens the lips in like an attempt to breathe.
So what does this baby need?
Baby needs breathing support. So we need
oxygen.
Yeah.
Okay. Color?
Baby seems to be cyanosed.
Okay. We move to, after we have activated the team, we move to?
Now we can progress to, wait, we hadn't finished circulation. We just said baby looks cyanosed.
Yeah, that is color, that is circulation.
Yes, but now we need parameters. We need the vitals for the baby.
Where do we get the vitals? At which stage?
In our primary.
At the secondary assessment. So the next assessment we move to is there. So we do initial then?
Then primary.
Then primary. Now at primary, we will get some vitals within there. Likely, in fact, all of them. So primary, you start with the airway, right? How is this child's airway?
Literally possible to assess because you can't hear if baby is crying, so you can't make it patent or not. But I would say patent because baby is still able to breathe in.
Okay. Breathing. You find an RR of 50.
Okay.
Yeah.
In, how old is our baby exactly? Baby looks like an infant, actually.
Yeah. Estimate.
Okay. So if baby is an infant, I would put the breathing rate of an infant to be between 30 to 53. So we are within normal, but approaching
Okay.
the higher side.
Mm-hmm.
That's on our breathing. Our SpO2 is low at 71. So now that
Yeah.
we've given oxygen, we'd want to supplement with an rebreather mask. We can't really rely on prongs.
Okay.
Yes, and then now from there we can assess the adequacy of the breathing, if there's any extra breath sounds, equal chest rise and fall after now our oxygen administration.
So, is it possible for our SpO2 to mislead us?
In terms of what?
Like for it to be inaccurate?
It could be if our machinery is defective.
No, the
because
machinery is working fine. Are there
mm,
any situations where our SpO2 should be taken with a pinch of salt?
um,
So I'll kick you off. Like let's say in anemia, you wouldn't
because now
trust your SpO2 100%, would you?
no, not really. It's not a true depiction.
Yeah. When else? When else would you sort of take it with a pinch of salt and go with the patient's clinical presentation?
When there is
In shock
no
as well.
over
Shock,
um,
cold conditions, okay? Um, cases of carbon monoxide poisoning, cases of anemia. So in such cases, if there's a disconnect between your findings on the SpO2 machine and the clinical condition of the patient, always go with the clinical condition of the patient. Uh, Continue. So breathing, you said, is fine after you supplement
yes,
oxygen,
we reassess to see whether we have an improved
improved
SpO2, whether
saturation.
our yes.
Move to circulation now.
So circulation, we assess the extremities of the baby. We start from the palms. We look for capillary refill. It's 4 seconds, so it's slightly prolonged. Then now we look at palmar pala. We look at the pulse rate. I can see the pulse rate is written to be 66. If we're dealing
Yeah.
with infant, pulse rate, we anticipate it to be between 100 to 180. So we have a low pulse rate. So we
So what
have
are we dealing with there? A low pulse rate is a?
Bradycardia.
Yeah. What does the ECG tell us? What kind?
It looks like a sinus brady, because I can appreciate a P before every QRS.
Okay. So a sinus bradycardia. Um, there are signs of shock. So what staging of shock are we dealing with here? Is it compensated or hypotensive? Ruth, is it compensated or hypotensive?
I would put it at, wait, let me look at systolic. 8/48. I would put it in hypotensive.
What's your expected systolic for an infant? A minimum of
72.
70. 70. Anyone less than 1 year? 70. 1 year and above, 70 plus 2 times the age. So this guy's systolic BP is still above 70. So compensated or hypotensive?
Okay.
I think
Then
it's
now I would,
compensated.
yeah.
Yeah, it's still compensated, but we are in shock. We are in shock. So this patient, what are we dealing with? Respiratory, circulatory, or an arrhythmia?
Let's look at what's the primary, the worst derangement. I would put it as circulatory.
Circulatory issue. Okay, very good. For Benson, I don't have both videos. So Benson, maybe you just give us the initial assessment, your initial assessment for this child in terms of appearance, work of breathing, and color or circulation. What do you think about appearance?
In appearance, the interactiveness, I don't think the child is interactive enough.
Okay, so we judge by what they do with their environment. Watch this. What are they doing with that pacifier?
They're sucking it.
So are they interacting with it?
Yeah, I think they're.
Yeah, possibly. It's a bit trickier to assess, especially on video, because you can't really stimulate the child and hear what they have or see what they do. We can't. But I'd say based on how they're behaving with the pacifier, having seen a case where they were not really interacting with their pacifier, I'd say this one is a bit interactive. The other things we can't assess because they are looking away. What about work of breathing? What do you think? Are they breathing normally? Benson. Benson, is there normal breathing? Okay, seems like Benson dropped off. So there's increased work of breathing. So possibly that child requires a bit of oxygen. Okay. I want us to then go to specifics. Now, I said there are different pathways to a cardiac arrest, okay? But in pediatric patients, the commonest cause of collapse are respiratory issues. So respiratory could be circulatory issues, or it could be an arrhythmia. That is how you should categorize your challenges. Now, respiratory issues, the patient could be in respiratory failure. Respiratory failure. So you must be capable of identifying respiratory failure. Or they could go into respiratory distress. And if nothing is done about it, they get to respiratory failure. Now, once they get to respiratory failure, they go into cardiopulmonary arrest, and they eventually go to cardiac arrest. Circulatory, this patient could be in shock, and if you don't intervene, they end up in a cardiac arrest. arrhythmias due to things like VFib or pulseless VTAC. Patients could end up in cardiac arrest, particularly abnormal kids born with congenital heart disease. However, an added one, they could be in like bradycardia or tachy, which could lead to shock, so cardiogenic, leading to your cardiac arrest, or any other arrhythmia that leads to your cardiac arrest, that leads to shock and then cardiac arrest. Those are the channels. So you need to recognize early where you are at and intervene. Okay, so that is our tip. So let's start with respiratory. Let's start with respiratory issues, and then we will discuss afterwards. So we are watching a video, then we discuss.
Or product. In order to show skills clearly, the healthcare providers in this video do not always use recommended personal protective equipment, such as gloves. To help improve your assessment skills, the American Heart Association training series includes videos of actual children with medical problems. And of course, at no time was medical care delayed for the purpose of obtaining this video. All children received timely and appropriate medical care, and parents provided consent before recording. Learning how to assess and effectively manage a respiratory emergency is a crucial skill for a healthcare provider. In this segment, we'll review the unique characteristics of the pediatric airway, learn to recognize the various types of pediatric respiratory emergencies, and show the proper equipment and appropriate techniques to manage them. First, let's review the unique attributes of a child's airway. These illustrations of an adult, a child, and an infant show that the airways of children and infants are considerably smaller and shorter than those of adults. The adult larynx is cylindrical, with the narrowest opening at the level of the vocal cords. In contrast, the larynx of infants and young children is funnel-shaped. The airway continues to taper below the vocal cords to the cricoid cartilage, which is the narrowest point of the airway, and it creates a non-distensible ring around the airway. In infants and toddlers, the tongue and epiglottis are relatively large and can contribute to airway obstruction. In addition, the larynx is positioned more superiorly and anteriorly than in adults. Note that the airway is always anterior to the esophagus, and the cricoid cartilage is the only complete cartilage ring located below the vocal cords. Keep these anatomic and physiologic details in mind when we discuss various respiratory emergencies and their treatment.
As you would with any seriously ill child, you should use the evaluate, identify, intervene sequence to respond to a pediatric respiratory emergency. When assessing a child, there are basically 4 different types of respiratory problems to identify: upper airway obstruction, lower airway obstruction, lung tissue disease, and disordered control of breathing.
This child with upper airway obstruction, such as croup, typically has increased respiratory rate and effort. Signs of increased effort include retractions and nasal flaring. Retractions occur in children because of their increased chest wall compliance and the negative intrathoracic pressure. A child with upper airway obstruction often has inspiratory stridor, a high-pitched inspiratory sound, hoarseness, and a barking cough. Other signs of upper airway obstruction may include drooling, snoring, or gurgling sounds. Responsive older children with upper airway obstruction often position themselves in a way that makes their breathing easier. They should be allowed to remain in a position of comfort. A child with lower airway obstruction, such as asthma or bronchiolitis, also has increased respiratory rate and effort. On auscultation, air movement may be decreased, exhalation may be prolonged, and you can usually hear expiratory wheezes. A child with lung tissue disease, such as pneumonia, demonstrates increased respiratory rate and effort that may include grunting. Crackles and decreased air movement may be present. A child with disordered control of breathing, such as a child with brain injury or drug overdose, may have an irregular breathing pattern. The respiratory rate is often slow, and breathing may be shallow with inadequate respiratory effort. Air movement may be normal or decreased. A child with disordered control of breathing may have poor muscle tone or a decreased level of consciousness, causing upper airway obstruction.
Once you've identified the category of respiratory emergency, you can then intervene. Intervening can be as simple as positioning the child. For infants and young children, the best position might be in the arms of the parent or caregiver. Allowing the child to remain in a comfortable position often decreases the child's anxiety and subsequent work of breathing. A common respiratory intervention for children is administering inhaled medications by using a nebulizer.
Components of a nebulizer assembly include a T-piece, plastic oxygen tubing, a nebulizer or atomizer bottle or reservoir, a mouthpiece or mask, and an oxygen source or compressed air. The nebulized medications are used to treat airway obstruction by opening the airway through either decreasing airway edema or improving bronchoconstriction. A cornerstone of treating respiratory emergencies in children is administering oxygen. You may choose to use several types of oxygen delivery devices, depending on the severity of the child's condition. Now, these devices vary in the oxygen flow rates used and delivered, and in the oxygen concentration delivered.
You'll want to use low-flow oxygen systems when a child requires a relatively low inspired oxygen concentration and is relatively stable. These systems deliver oxygen mixed with room air during patient inspiration. The oxygen concentration delivered by these systems is determined by the oxygen flow rate, the child's breathing volume, and the child's respiratory rate. With low-flow systems, the lower the oxygen flow, the lower the inspired oxygen concentration. Examples include simple nasal cannula and simple masks. A simple nasal cannula is generally used with flow rates of 1/4 to 4 liters per minute. A simple oxygen mask requires at least 6 liters per minute, but 6 to 10 liters is generally provided.
Some patients will need more support than a low-flow oxygen system. High-flow systems may be helpful for these patients. They come in two varieties, those that have variable oxygen concentration and those that do not. These systems include a mask that is tightly sealed against the face, one-way valves that allow patients exhalation but no entrainment of room air, and a reservoir bag. A commonly used high-flow system is the non-rebreathing face mask. One advantage of this device is that it allows you to easily deliver consistently high concentration of oxygen approaching 100%. Non-rebreathing face masks are always connected directly to oxygen. The oxygen flow rate for the mask must be at 10 to 15 liters per minute. The flow rate should be adequate to keep the reservoir bag partially expanded. If the mask is tight-fitting, one-way valves ensure the child breathes only oxygen from the oxygen source or the reservoir. No room air is drawn in. Non-rebreathing masks should be used in emergency settings when the patient is breathing spontaneously, but high concentrations of oxygen are required to maintain oxygen saturations.
Another high-flow system you'll encounter is the high-flow nasal cannula. These have become very common in the inpatient and ICU settings. Now, the flow can be adjusted from 4 liters in infants up to 40 liters or more in adolescents. You can also titrate the flow to provide additional inspiratory and expiratory pressure. This may improve the patient's work of breathing. High-flow nasal cannula systems deliver a combination of both room air and oxygen. They allow healthcare providers the flexibility to also titrate oxygen concentration based on the patient's needs and saturations.
In the most serious respiratory emergencies, effective ventilation may require positive pressure. In these circumstances, the use of a bag mask device is the most important life-saving skill you can perform. Bag mask ventilation using a bag with an oxygen reservoir can deliver an oxygen concentration near 100%. This requires an oxygen flow rate of at least 10 liters per minute. When properly performed, bag mask ventilation can be as effective as ventilation through an endotracheal tube for short periods of time.
When bag mask ventilation is needed, healthcare providers must be ready to perform two other interventions: suctioning the airway and inserting an oral airway.
When supporting the airway and breathing of a child, you may find you need to clear the airway. That may include suctioning of secretions, blood, or vomitus. Suction devices can be either portable or wall-mounted. Those used in children should have adjustable suction regulators so that you can minimize tissue trauma. Semi-rigid pharyngeal tips and various sizes of catheters should be available. Complications from suctioning may include hypoxia, vagal stimulation, bradycardia, gagging and vomiting, soft tissue injury, and agitation that may further compromise the patient's cardiorespiratory status.
To suction the oral pharynx, gently insert the distal end of the suction catheter into the oral pharynx over the tongue. Guide it into the posterior pharynx and apply suction by covering the catheter side opening. At the same time, withdraw the catheter with a rotating or position of hypoxemia. You may give 100% oxygen immediately before and after each suctioning attempt. Monitor the child's heart rate, oxygen saturation, and clinical appearance during suctioning. In general, if bradycardia develops or clinical appearance deteriorates, interrupt suctioning and deliver oxygen and bag mask ventilation if needed, until the heart rate and clinical appearance return to normal. Inserting an oral pharyngeal airway is another intervention that healthcare providers must know how to do. Oral pharyngeal airways are used in unconscious patients with no gag reflex. They help maintain the airway by preventing the tongue from obstructing the tracheal opening or glottis.
Well, an appropriately sized oral airway should extend from the corner of the mouth to the angle of the child's jaw when the airway is positioned next to the face. If the device is too large, it may block the airway, and if it's too small, it can cause the tongue to obstruct the airway. One technique to facilitate insertion of the oral pharyngeal airway is to use a tongue blade to depress the tongue. The oral airway should not be used in conscious, responsive children. It'll likely cause a gag reflex and vomiting.
Often, an oral airway will not provide sufficient airway support, and you'll need to insert an advanced airway. For example, if it's difficult to provide effective bag mask ventilation, if the patient has actual or potential airway compromise, particularly with long transport times, or if you need to protect the airway. Advanced airway devices such as endotracheal tubes and laryngeal mask airways offer many advantages. These include reducing the risk of aspiration and gastric insufflation, and eliminating the need to interrupt chest compressions to deliver breaths during CPR. If an advanced airway is inserted during CPR, you should minimize how often and how long you interrupt chest compressions for intubation. Once you correctly place the tube, deliver one breath every 2 to 3 seconds asynchronously, while continuous chest compressions are delivered without interruptions. Another advanced airway device is the laryngeal mask airway. This device offers two key advantages. It can be inserted without directly visualizing the glottis, and it can be used as a rescue device when endotracheal intubation cannot be accomplished.
If sudden deterioration is observed in a patient with an advanced airway, it may be caused by one of several complications. You can use the mnemonic DOPE to help remember these. The airway may be displaced. For example, an endotracheal tube may be pulled out of the trachea or advanced into the right or left main bronchus. Obstruction of the airway may be caused by secretions, blood, pus, or a foreign body. Kinking of the airway may also cause an acute obstruction, particularly in smaller endotracheal tubes. A pneumothorax usually results in decreased chest expansion and breath sounds on the affected side. A sudden deterioration in the patient's pulse oximetry may occur. In severe cases, hypotension and even cardiac arrest may occur. It rarely happens, but sometimes your equipment can fail. Disconnection from the oxygen supply, power failure to a mechanical ventilator, malfunction of valves, or a leak in the bag mask device or circuit.
Respiratory problems are the most common pediatric emergencies. That's why it's essential that you understand the unique characteristics of the pediatric airway and you know how to recognize and manage these life-threatening conditions.
Okay, so I think this is actually the most important lesson when it comes to pediatric advanced life support. And we had already started touching on it. Usually, the patient, when it comes to respiratory issues, could be dealing with one of the following types of respiratory issues. Types of respiratory issues. Include, number one, upper airway obstruction. Upper airway obstruction. Now, what are some of the causes of upper airway obstruction? Daniel.
Trauma, foreign body,
Foreign body,
secretions.
airway obstruction, trauma, secretions.
I think mostly in kids, they're just those infections, maybe, and anaphylaxis.
Yes. Group, hepatitis.
I think also anaphylaxis, for example, in the event whereby you find someone has a pharyngeal swelling.
Yes. Anaphylaxis. How would they present? What is a unique presentation to upper airway obstruction?
Stridor.
Stridor. Now, when it comes to management, that is where your assignment is. Please go and have a look at how we manage. If we are talking about group, how do we manage mild group? How do we manage moderate? How do we manage severe? Okay. When it comes to anaphylaxis, how do we manage? FBAO, I know we already know. Depending on the age, we'll do either the abdominal thrust or 5 back blows alternating with 5 chest thrusts. So go and have a look at how we manage. Lower airway obstruction. What are some of the causes? Ruth, what are some of the causes of lower airway obstruction?
So we have COPD, we have asthma. Okay, but for pediatrics, we don't expect COPD. So we could have asthma, we could have bronchiolitis, pulmonary edema.
That would be lung tissue for pulmonary edema. So bronchiolitis and asthma. How would the patient present?
With a wheeze.
Wheezing.
You'd hear, either an audible wheeze or an inspiratory, like auscultatory rhonchi.
Yes, and a prolonged expiratory phase. Prolonged expiratory phase. How do we manage? Depends again. Is it mild asthma? Is it moderate or severe? So please go and have a look. Please ensure you go through those sections of your manual before tomorrow. We have lung tissue disease. So lung tissue disease. What are some of the causes? Daniel.
Pneumonia.
Pneumonia.
Aspiration.
Yes, so that's still pneumonia.
chemical
Those are still pneumonia.
trauma.
Okay, lung contusion. Okay, so trauma, lung contusion. You can have pulmonary edema. You can have ARDS. Now, how would the patient present? How would the patient present? Or what sounds would you appreciate?
Crepitations, or what are they called? Crepitations, rather. Crackles, yeah.
Yes. And they would also possibly have grunting.
Grunting.
How do we manage? Again, kazi kwenu, kazi kwenu, kazi kwenu. Please go and read. Okay, number 4. Disordered control of breathing. Disordered control of. So some of the causes, actually, it's just CNS depression. So CNS depression can be caused by a traumatic brain injury, can be caused by toxins, can be caused by seizures. Presentation. Irregular breathing patterns. Irregular breathing patterns. So that is why when we were assessing, we assess for the regularity of the breathing pattern of the patient. So an irregular breathing pattern can cause can be a sign of your disordered control of breathing. Okay, there are other causes as well, such as tumors, hydrocephaly, and all that. But you get anything that causes CNS depression will result in a disordered control of breathing. So you want to find out what exactly is causing the problem. Now, more urgent, before you find out what exactly is causing the problem, you always want to stage. You want to stage the severity of the respiratory issue. So you always want to find out the severity of the respiratory issue. Am I dealing with respiratory stress, or am I dealing with respiratory failure? So is it distress or failure that I'm dealing with? And this severity can be assessed at the ABCs. At airway, in distress, the airway is usually patent and maintainable. It can be maintained. But when we get to failure, the airway cannot be maintained. So the airway is threatened. There's a need for an advanced airway adjunct. Okay? At breathing, in distress, there will be tachypnea and an increased work of breathing. In terms of SpO2, it improves with supplemental oxygen. But in failure, we end up with bradypnea or apnea, and decreased work of breathing. Patient is exhausted. Additionally, SpO2 remains low despite high flow oxygen. Despite high flow oxygen, patient saturation still remain below optimal, actually less than 90. That is concerning for failure. And what it means is that this patient cannot breathe on their own, hence requires assisted ventilation. They need help breathing, moving air in and out. Okay? Circulation. At circulation, when the patient is in distress, they typically present with tachycardia. Okay? They present with tachycardia. But in failure, they present with bradycardia. Okay? In terms of color, here you could have pallor. Here you'll have cyanosis or mottling. That patient has gone into respiratory failure. At disability, this patient is agitated or anxious, but they still have a good level of consciousness. Here is an altered level of consciousness. So that is how you can tell. Now, whenever we get to failure, you need to be more aggressive. More aggressive interventions. So advanced airway, assisted ventilation, whatnot. Distress, in addition to looking for the cause and treating it, you are possibly supplementing the oxygen of the patient, positioning, things like that. But with failure, you now need to be more aggressive. I hope that is clear. So in addition to trying to find out what has caused my respiratory issue, is it an upper airway? Is it a lower airway? Is it a lung tissue disease? Is it a disordered control of breathing? You also want to stage this patient in terms of severity. Am I in distress? And if it's distress, is it severe distress or moderate distress? Or am I dealing with so moderate or severe distress? Or am I dealing with a respiratory failure? Okay, and then you manage accordingly. Now, when it comes to management, this is where now we talk about airway management. Now, airway management, the first priority is always patency. So how do we achieve patency? For the unresponsive patient, we do positioning. So we do our sniffing or our neutral position, and we consider the need for suctioning. If it's a child, do not suction them for more than 10 seconds at a time. If it's an infant, never do suctioning for more than 5 seconds at a time, because you can cause hypoxia if you suction for too long. The second thing that we want to ensure beyond patency is we want to ensure safety of that airway. Now, the safety of the airway here, we are talking about use of airway adjuncts. So airway adjuncts, we have the basic one. Basic ones include the oropharyngeal airway and the nasopharyngeal airway. Ruth, how do we size a nasopharyngeal airway?
From the corner of the nose, not tip of the nose, the corner of the.
So it is tip of the nose. It is tip of the nose to the earlobe. Tip of the nose to the earlobe. Okay. What about an OPA?
OPA from the angle of the mouth to the angle of the mandible.
Yes, so corner of the mouth to the angle of the jaw. So corner of the mouth to the angle of the jaw. What kind of patient can you insert an OPA on?
Sorry?
What kind of patient can we insert an OPA on?
Any patient who does not have a base of skull fracture.
OPA, OPA.
Yes.
NPA, base of skull fracture. OPA. So of course, no facial injuries. But the most important thing is the gag reflex, Ruth. They should not have a gag reflex. So unconscious without a gag reflex. If you are unsure whether or not they have a gag reflex, what do you insert? The nasopharyngeal airway. So if you are unsure whether the gag reflex is intact or not, insert a nasopharyngeal airway. Those are, however, basic airway adjuncts. They do not really isolate the airway. So patients in failure want the advanced airways. Now, advanced airways, we have the supraglottic airway devices, and we have the definitive airway devices. So definitive airway devices or advanced airway devices, we are saying we want to insert them in patients who require an isolation of the airway. So patients who require assisted ventilation, we need to isolate the airway. Patients who are at risk of aspiration, those patients who don't have intact reflexes. So the unconscious patient with a GCS less than 8 possibly requires an advanced airway. Now, the supraglottic airway devices are one, laryngeal mask airway. Laryngeal mask airway is abbreviated LMA. So this is the laryngeal